Thank you, Christina, for the introduction and also for giving me the privilege to present this update. A personal thanks also to you for chairing me. I like Britta a lot, but this gong thing stressed me out like hell. These are my disclosures. Please note that I have potential conflicts of interest with study board participations. What I will try to do is to highlight some updates on concepts which have been discussed during the last state of the arts, meaning radiologically isolated syndrome, pregnancy and late onset MS. I will try to highlight some novel aspects on phase 3 trials on BTK inhibitors. I will come to something quite novel CAR T cells, which have also been introduced to Switzerland in the trial setting. And I will try to explain why I believe that Switzerland is really a good and attractive site for clinical studies such as CAR T cells. So starting with the concepts we have addressed the last times, radiologically isolated syndrome. You know, these are the non-patients, individuals who have a headache, who have a head trauma, or who are just like psychological students and go into the MRI for research purposes and pop up with lesions. And as you may know, without any symptoms, we call them radiologically isolated syndrome. And as you may also know, is that the current proposed criteria, the McDonald criteria, indicate that we should liberate the diagnosis of multiple sclerosis also in this very, very early cohort, that not only dissemination in space, but also already positive oligoclonal bands and or specific MRI characteristics such as central vein signs would be sufficient to diagnose a very early MS. Now, why is that? We do have some diagnostic markers. We also do have some prognostic markers. You know them. It's the younger age, younger meaning below 37. It's infratentorial or spinal cord lesions. It's gadolinium-enhancing lesions. It's CSF oligoclonal bands that are really prognostic. And if you have 3 out of these parameters I have mentioned, the majority of the patients or the people will develop MS symptoms within 10 years. However, that's obviously an ethical dilemma. Because we will increase the number not only of individuals with lesions, but really of patients, whatever that means. They don't have symptoms necessarily. It does have implications for therapy, as you know, but if we really, in exceptional cases or in single cases, think about therapy, there's an issue of adherence, how to monitor these people, how to try to help them to cope with this disease/non-disease. So I think there are many opportunities to discuss these kinds of individualization. The MSAB of the MS Society has issued a recommendation on that. Please read it up. Now, another aspect that I would like to highlight and reiterate is the issue of family planning, that many, many women with MS feel unprepared and uneducated. As you can see on the right-hand side, many females with an MS did not know that they are able, that they are / allowed to have children. And once they understand they are allowed to have children, they feel not very well educated in terms of what kind of immunotherapy they should have. And as a sort of no-brainer, more recent trials also indicated that postpartum, if you really start immediately with even high-efficacy treatment, it takes some time until these treatments work. So the bottom line of this is those females with MS need a very early and very rapid counseling. And I'm very glad to highlight that what we have discussed last year is now published. We do have Swiss-specific recommendations which really should aid all of us in trying to counsel females with MS. Another update on the sort of right-hand side, so it's older age MS or late onset or very late onset MS, whatever that means, not quite sure where I would fit in here. As we have heard before, the prevalence of so-called elderly is increasing. Not only the incidence, but of course because people survive longer, maybe also because of the DMTs. And this is why we have, like in the US, about 10% of the patients who are above 65 years old, and especially also in Italy, 18%. Now, this is a paradox, because these patients, the older onset MS patients, they are really in need. They are vulnerable because they do have a faster progression, especially also if they have comorbidities. But if we find a treatment, then they also obviously do have a higher risk of side effects. And that's summarized in this table. I'm not going to go through in here in detail, but just for different sort of high efficacy treatments, it's very clear that there's a clustering of risk in the older age population. The most prominent one is, of course, the PML risk. Now, it may lead to the constant benefit risk assessment that we in some patients think we should stop the treatment. We heard that before in this fabulous poster flash, that we have about a differentiation of between 55 to 45%, and also a considerable degree of patients who stop treatments. And we also heard that a lot of patients are on ocrelizumab or anti-CD20. So what happens with them if we stop? And this is a kind of result that we would have predicted. If you stop this high efficacy treatment in elderly patients, almost 60 years old on the left-hand side, then it's quite clear that the risk of relapses increases after the stop of blocking substances, natalizumab, fingolimod, but not after CD20. Another means to try to stratify the risk is very early on, when you already diagnose late onset MS. So, and this is also proposed by the expert group with the 2024 McDonald criteria, that we take specific caution when we diagnose elderly patients here above 50 years, and that we try to find some additional features, confirming features which increase the specificity or the positive predictive value of our diagnosis, a spinal cord lesion, positive CSF, or again, the central vein sign. Now let me move to the second part. The unmet need is very clear, is the progression in whatever phenotype it may come. And on the right-hand side, you see what kind of mechanisms currently are hypothesized to be involved in this progression. And they are very often confined to the CNS, be it either the meningeal inflammation, for example, with lymphocytes, or the sort of widespread white matter inflammation carried by microglia. And another substance class, the so-called Bruton's tyrosine kinase inhibitors, BTK inhibitors, at least promise that they do have the capacity to tackle some of these pathophysiological aspects. BTK inhibitors, BTK, the enzyme, a tyrosine kinase, is coined after Ogden Bruton, who in the early 50s diagnosed some children with a phenotype of X-linked gamma globulinemia. It took some while until the genetic defect and the underlying pathophysiology became clear, but that really led to the identification of that enzyme, which is prominent in B-cell maturation and also myeloid cell activation. And it did not take long, 2013, until the first generation BTK inhibitors were approved in certain hematological malignancies. Now here we're talking about new generation, second generation BTK inhibitors, which carry the promise of less off-target side effects, and where we now, and this is what I will try to present now, have phase 3 clinical data in MS. First one is evobrutinib. a trial which was shown last year already, but now has been published. And what you can see here is very disappointing. Be it the primary endpoint in 2 parallel studies, the adjusted annualized relapse rate, or on the right-hand side, the confirmed disability progression, this is all negative in comparison to the active comparator teriflunomide. Not only that the efficacy data is negative, but also there pops up a significant safety signal, which is inherent to BTK inhibitors. This is liver toxicity. What you can see up there is like, yes, there were a lot of patients with very high increases of transaminases, but I think the most noteworthy thing is here in the last line, which is the Hy's law. What is the Hy's law? The Hy's law is a combination of transaminases, upper 3 times upper limit of normal, combined with bilirubin, total bilirubin, upper 2 times upper limit of normal. And if you do not have any other indication for any differential diagnosis, this is believed to predict a risk of about 10% liver failure. 10% liver failure. So this is a truly biochemical, strong risk signal, one has to say. Now, it's very clear that one has to ask, why did this study fail? One aspect could be the study population. It was not very active. The other thing was that in our expectation, teriflunomide did overperform, but the other thing could also be, yes, let's face it, these trials were conducted during COVID pandemic and also when the Ukraine war started. So about 80% of the participants came from Eastern Europe, about 40% from one of the countries which were associated in the war. So the discontinuation rate in that trial is relatively high. And when you go into detail, you can see that in Eastern Europe, there were less subjects reported with confirmed disability progression for whatever reason. What I'm trying to say is here, I don't think this really explains the lack of efficacy. But here, what we see is even in a well-controlled trials, we do have many, many confounders, which are very, very difficult to adjust for. So the more important it is to look for other phase 3 clinical trial data with other substances, with other biochemistry, but which may also have other confounders or reduced some of these confounders. And one of these substances is tolebrutinib, another BTK inhibitor. These trials have been presented during the last ACTRIMS, and I will give a short summary. So again, there was one trial on relapsing MS, active relapsing MS, and again, similar to evobrutinib, if you look at the 2 parallel trials here on the right-hand side, the pooled data, the primary endpoint, annualized relapse rate, was not met in comparison to teriflunomide. Interestingly, in this relapsing trial with a relatively low number of relapses, there still was an effect on time to confirmed 6-month confirmed disability worsening. In that really against teriflunomide, which does have evidence-based an effect on disability progression with a superior effect of tolebrutinib. So this raises the question, how about an even more, a population even more in need of such a substance? How about secondary progressive MS, and here specifically non-relapsing secondary progressive MS? And this is the trial design, tolebrutinib against placebo. You know that the agents that we are having approved for SPMS are really probably working best, if one can say conservatively, in those patients who still have focal activity. So this was an attempt to select for patients with less focal activity. What kind of baseline did these patients have? They were elderly, almost 50 years old. They had a quite severe EDSS of almost 6, and they had a quite long time after the last MS relapse. So really a true and quite severe secondary MS population. And interestingly, the time to 6 months confirmed disability progression as primary endpoint was met. In that, if you look at the 25% percentile, there's a strong and clear delay of the time to disease progression in the tolebrutinib treated patients in comparison to placebo. How about sort of the inverse, time to confirmed disability improvement? And yes, also here, there is some efficacy indicating that the data may have some robustness. However, no rose without thorns. Of course, there were side effects. Side effects, if you look in general, were mostly related to upper respiratory tract infections. COVID-19, no wonder this was in the during the COVID-19 pandemic, not nasopharyngitis, but also influenza. However, again, like in the other trial, we did see some liver biochemical abnormalities with a transaminase increase, but also cases with Hy's law. And unfortunately, this has to be said in clarity. One patient had to undergo a liver transplant because she experienced a liver failure and subsequently died. There have been measures now introduced, and we may want to discuss that a bit later on, how to reduce that liver toxicity, but the real outcome we will have to see. Now, I said something about benefit risk. I think this is still with the authorities, of course, to decide about the ultimate benefit risk, but also for us as physicians, what kind of risk we are willing to take for these patients in the light that these patients do not really have too many treatment alternatives. This is a bit the pipeline of potentially interesting substances in chronic progressive MS, and also results presented at last year's ACTRIMS. They were disappointingly negative, again, especially for the statins, something that many of us had quite a lot of hope in. Now let me switch to the last part. I want to highlight a novel aspect which is very vividly discussed in the autoimmune field, and now also in MS and also in Switzerland. This would be the CAR T cells, chimeric antigen receptor T cells. What are chimeric antigen receptor T cells? These are T cells engineered to express an antigen specific receptor, which is not MHC dependent. And this is fused on the left-hand side to co-stimulatory molecules. In other words, this is a way to bypass antigen-presenting cells. So you can imagine the generation, the engineering of these cells is quite cumbersome. The patient has to give T cells. This is not so difficult, but these T cells, the autologous cells, have to be selected, purified, have to be engineered, have to be expanded, and then after a lymphodepletion of the patient, they have to be transfused back. So it's a time-consuming and also resource-consuming procedure. Now, apart from selectivity of that antigen, for example, for CD19, there's another hope in this CAR T-cell approach, which is the sort of in-depth depletion of pathogenic cells. And that's shown here in the animal model, EAE, a B-cell dependent EAE model, where you see here in a sort of whatever that color is, rose or something, and in the peripheral blood you see a profound depletion of CD19 B cells, which makes sense, but also in the tissues, and most importantly in the CNS, you have a clear and profound depletion of B cells in comparison to anti-CD20 monoclonal antibodies. So it's quite clear you have a profound and thorough depletion of B cells. Now, this also, of course, does carry risks because you have obviously T cells entering a brain, maybe in the case of MS, a pre-damaged brain. So this can cause side effects. And one side effect quite prominently described in tumor patients would be the so-called immune effector cell-associated neurotoxicity syndrome, the ICANS. What is this? It appears in about 1/4, probably a bit less, of the patients. It appears early on, as you can see on the left-hand side, so the x-axis is days. And what you can also see is it does not last too long, in median about a bit more than a week or so. But it can be cumbersome. It goes along with cognitive deficits, which interestingly we can pick up quite sensitively with MOCA. And as a very early sign, patients have a tremor. This is indicated also on the left-hand side, the black triangle. Before even other signs, the tremor kicks in. And this tremor may also have something to do that they have handwriting abnormalities. So most often they have a micrographia, such as we see with Parkinson's patients. So this is something where we as clinicians on the bedside do not normally pay too much attention to, but this is certainly something which one needs to highlight. I indicated that these ICANS is prominent in tumor patients. So how about in patients, MS patients with a pre-damaged brain? It could be that these side effects are even exacerbated, couldn't it? So here's the case report of 2 progressive MS patients, and it focused on safety, on survival of CAR T cells, and maybe some proxies of efficacy. And on the left-hand side, you see the treatment history. Noteworthy is these were patients pre-treated with ocrelizumab. So this was a sort of course, rescue therapy. And then on the right-hand side, you see in green the EDSS, which remained stable over 100 days or so. And in red, you see the CAR T cells in the periphery. And what you can see is, yes, they survive. And sometimes they even expand. And if you look at the CSF compartment, at least in one of these patients, it also expanded. Quite reassuringly, especially also in this patient where you had a CAR T cell expansion in the CNS, there was no sign of ICANS, which is good news. And also in one of these patients, there was a decrease or loss of oligoclonal bands, also quantitatively. So indicating, yes, there may be some efficacy of these cells. So this is as good as it gets. Where are we in terms of clinical trials? With, beautiful names which have been coined, one-and-done therapy, stuff like that. There are, in autoimmunity, novel trials initiated, also in 2024 in multiple sclerosis, and also trials in Switzerland with either relapsing MS, with focal activity despite high efficacy therapy, or also progressive MS with EDSS progression more recently. Why do I highlight this is so important with Switzerland? Because, of course, this is something that we were looking for our patients, but these studies are highly difficult. They need a lot of infrastructure. Risk number 1 for these studies and for our patients is, of course, that they just don't have access to these trials. So smaller Switzerland is an ideal country, I have to say. There may be delays with the clinical procedure. I talked about the leukapheresis. I talked about then the industrial engineering and expansion of the cells, the shipping back and forth. So this is all cumbersome, time-consuming, and needs a high degree management, really. So do the patients afterwards because of all these potential side effects. And I think this highlights why Switzerland with these kinds of substances could be very well suited. So let me end 5 minutes in advance. I was too stressed. So I think we have a much better evidence now for the management of vulnerable patients, even with elderly patients. The BTK inhibitors, the current state is that tolebrutinib is finalizing its files for registration or for approval. There could be a novel approach, but yes, probably there has to be a further development because the benefit-risk profile needs certainly to be improved. What I find very interesting is with this kind of approach, we, for the first time, really have a proof that our concepts of so-called smoldering inflammation may really be true. The pipeline is active, and as I indicated, Switzerland is attractive. However, if we want to do these kinds of treatments, we need to work together. Not only, highly specialized centers, but all of us, including also general practitioners and, of course, outpatient neurologists. And in order to try to improve synergies and collaboration, I think these activities by the Swiss MS Society, by the Swiss Neurological Society, Caroline is here, together also with gynecologists, for example, to guide to draft these guidelines are paramount. With this, I end. Thank you very much.